KMCH Coimbatore, and we have Sneha today with us. She's the final year postgraduate dependent student with us, and thanks for giving us the opportunity to present this case today. I hope it will be educational to all of us. And welcome to Dr. Neha also. She's my co-panelist.
Hello.
And if you have any questions, please feel free to type in the chat box. We'll pick it up and we'll try to respond to as many questions as possible. So we'll get started. Sneha.
Yes, sir. Good evening, ma'am. Good evening, sir. Good evening, all. Here, I'm going to present a case on carcinoma larynx. A 75-year-old male who's a chronic smoker with no comorbidities, who's a known case of carcinoma glottis T1N0M0, treated with radiotherapy in March 2021 with complete disease response. Now presented with complaints of change of voice since 3 months, complaints of difficulty in swallowing since 2 months, and complaints of noisy breathing since 2 weeks. History of presenting illness: hoarseness of voice since 3 months, insidious in onset, progressive in nature, non-remitting, with no near normal voice episodes, no aggravating or relieving factors. History of difficulty in swallowing since 2 months, insidious in onset, progressive in nature, more for solids than liquids. No history of cough on taking oral diet, no aggravating or relieving factors. History of loss of weight and appetite, more than 10 kgs over past 3 months. History of difficulty in breathing since 2 weeks, which was insidious in onset, progressive in nature, initially was mild on and off only during exertion, gradually progressed, now present throughout the day, even at rest, with no positional variations. Not associated with chest pain, not associated with evening rise of temperature. No history of coughing of blood, no history of vocal abuse, no history of ear pain, ear discharge, or hard of hearing. No history of nasal obstruction, nasal discharge, or headache. Past history: as previously mentioned, he is a known case of carcinoma larynx T1N0M0 treated with radiotherapy of 55 gray in 20 fractions, targeting glottis and bilateral neck level 2 to 4. So here is the video of fiber optic laryngoscopic showing the first presentation of the patient before radiotherapy, that is proliferative growth localized to the right vocal cord. So the second video shows post radiotherapy FOL.
Yeah, so let me stop you right there.
Yes, sir.
So initially the patient, before any treatment was given, he came with hoarseness.
Yes, sir.
And the first video, can you play that first video again?
Yes, sir.
So this is the first time the patient is presenting to the hospital with hoarseness as the only complaint. And he has no previous head and neck disease. And this is the fiber optic examination, right? So
yes,
can
sir.
you describe the findings that you see?
So here there is a proliferative lesion occupying the right true vocal cord, and rest of the laryngeal structures are normal with bilateral vocal cords mobile. So the staging is T1N0M0.
Okay, what other findings do you look for in a fiber optic scope in this particular situation?
I look for the structures right from the base of tongue, vallicula, epiglottis, aryepiglottic fold, any pooling of secretions in bilateral pyriform sinus or in the postcricoid region, fixity of larynx.
And finally, whether the airway is adequate.
Yes, sir.
Okay. So this patient received radiation, and then yeah, carry on.
Patient received radiation of 55 gray in 20 fractions, targeting glottis and bilateral neck, that is level 2 to 4. And this is the post radiotherapy follow-up fiber optic laryngoscopy of the patient, where he had a complete disease response to radiotherapy and he is free of disease. Here you can see bilateral cords mobile and there is no obvious evidence of disease.
Okay, so this patient present with carcinoma glottis, And what is the risk of nodal metastasis in carcinoma glottis?
Sir, vocal cord, since it is has a least nodal metastasis because of lack of lymphatics. There is no submucosal lymphatics, so they have very low risk of spread to neck nodes.
Correct. So this patient would have had, if the patient had had radiation just confined to the larynx, that would have been appropriate treatment also. So there was
Yes,
no
sir.
need to treat bilateral necks because the patient would have had a very low risk of nodal metastasis, like you correctly said, and the glottis has a very poor lymphatic supply.
Yes,
If
sir.
this patient had a supraglottic tumor, then if radiation was chosen as a primary modality, then he would have had radiation to the primary laryngeal tumor as well as bilateral neck nodes.
Yes, sir.
Yeah. So
Yes,
what
sir.
neck nodal levels are at risk for carcinoma larynx?
Level 2, 3, 4.
And
6, sir.
correct. Yeah. So the level 6 nodal level should also be considered in the treatment if you are going to give treatment for suspected nodal metastasis.
Yes, sir.
Okay, carry on.
Okay, sir. There is no history of neck trauma, neck surgery, or pulmonary tuberculosis. No history of any known comorbidities. No history of any drug allergy. Personal history: he is a known chronic smoker. Since past 20 years, he smokes 4 to 5 cigarettes per day. On an average, the pack years is 5 pack years. He is not an alcoholic, and there is no history of betel nut or pan chewing. He takes mixed diet, normal bowel and bladder habits. Sleep pattern is normal. Family history, there is no significance.
Okay,
General
okay.
examination.
So how do you calculate the pack years for smoking?
So number of cigarettes smoked per day into number of years he had smoked divided by total number of cigarettes in a single pack, that is 20.
Okay, so that captures the intensity of smoking as well as the duration.
Yes,
So
sir.
intensity is how many cigarettes he smokes in a day, and duration is obviously the number of years he has smoked. So for example, if a patient smoked 10 packs a day for 1 year, he will have a similar risk to a patient who smoked 1 pack for 10 years. So it takes into account both these factors.
Yes, sir.
So what are the risk factors for carcinoma larynx?
Like smoking, tobacco, any form of tobacco, like tobacco chewing, pan chewing, and then exposed to chemical fumes for people who are working in chemical industries, and exposure to cement factories which have the exposure of aromatic acrylic hydrocarbons, benzene.
Okay, good. More common causes?
Alcohol has a synergistic effect with smoking.
Okay, anything else?
Sir, human papilloma virus infection.
Yeah, childhood recurrent respiratory papillomatosis is a risk factor for adult onset laryngeal cancer.
Okay.
Any other risk factor you're aware of? So gastroesophageal reflux has been mentioned as a risk factor. It's not
Okay.
very high in the list, but some studies have shown it may have a contributory role in laryngeal cancer.
Okay, sir.
Dr. Sneha, I just wanted to ask, you have given the details of the addictions, but since the patient has once undergone the treatment for his laryngeal cancer and again developed the symptoms, this is what I have perceived from the history.
Yes, sir. Yes,
Right.
ma'am.
So
Yes.
was he ever off his addictions? Because every time we actually offer the patient treatment for malignancy, we do first and foremost go for smoking cessation and de-addictions. So has this patient been off his addictions or he is still continuing? Because this has some impact when we are offering the treatment for this recurrence also.
Yes, ma'am. He was off smoking, ma'am.
Yeah, so you should have mentioned that he is now, he has quit his addictions for so many months or after he was offered his treatment or started his first treatment, right? So just
Okay, ma'am.
to make a
Okay.
mention of that.
Okay, ma'am. Sure.
Okay.
General examination. Patient is conscious, oriented, moderately built and nourished. No pallor, icterus, cyanosis, clubbing or generalized lymphadenopathy. No pedal edema. He had mild, noisy breathing present during the examination. These are his vitals. Examination of oral cavity. Lips, gums, angle of mouth were normal. Teeth, nicotine stains present. Gingivobuccal sulcus and gingivolabial sulcus, buccal mucosa, retromolar trigone, anterior two-third of tongue and floor of mouth were normal. Hard palate also had nicotine stains. Examination of oropharynx, posterior one-third of tongue normal. Soft palate had nicotine stain. Uvula, bilateral anterior and posterior tonsillar pillar was normal. So the indirect laryngoscopic examination showed the posterior one-third of tongue, bilateral vallicula, glossoepiglottic fold and pharyngoepiglottic fold were normal. Bilateral airy epiglottic fold normal. The right false chord and the true chord region had a submucosal bulge seen along all length, causing narrowing of the glottic airway. The left false chord and true chord were normal. On phonation, the left hemilarynx was mobile, the right hemilarynx was fixed. Bilateral piriform sinus had pooling of saliva. This is the fiber optic laryngoscopy, which here shows a submucosal bulge occupying the right true chord and the false chord region, and there is fixity of right hemilarynx with pooling of saliva in the bilateral piriform fossa. The left side is mobile. Going on to neck examination, the external laryngeal framework looked normal. There was no splaying of thyroid cartilage. Trachea appeared to be in midline. There was no swelling, scars or discharging sinuses in the neck. The inspectory findings were confirmed on palpation. There was no laryngeal tenderness. Laryngeal crepitus was present. No bruit felt.
Okay, Sneha, let me stop you there. So
Yes,
how
sir.
will you examine the neck?
We'll make the patient sit. The examiner should go behind the patient and palpate on. For neck nodes, we should just roll our fingers over the neck from anterior to posterior aspect, covering all the levels of nodes. And also, we should feel for laryngeal crepitus and any tenderness over the neck.
So if you follow a methodical, if you follow the neck examination steps methodically, you won't miss any finding. So
Okay, sir.
like you said, make the patient seated comfortably. Neck should be neutral. It shouldn't be flexed or extended.
Okay, sir.
And then 1A, and then come along the lower border of the mandible, level 1B, and then come along the jugular group of nodes, levels 2, 3, and 4, and then palpate the supraclavicular area and the area just above that, which will cover level 5, and then the pretracheal and prelaryngeal nodes, level 6, and then you'll palpate the occipital nodes behind in the posterior aspect of the scalp. And then you complete the examination by palpating the parotid and the thyroid gland. And then finally, you should examine the scalp also for any scalp cutaneous lesions that could be the root cause for neck lymph node enlargement.
Okay, sir.
Right? So go back to the previous slide. So this patient you said had mild stridor, right?
Yes, sir.
So is there a grading system for stridor? Like, is there a mild, moderate, or severe grading system? I'm not aware of any. So how do you grade the stridor as mild, moderate, or severe? There is, as far as I know, there is no
Grading.
grading system. But if a patient has severe stridor, How will his presentation be?
The noisy breathing will be continuous and will be very much audible, and he'll have accessory muscle. The accessory muscles of respiration will be prominently seen, like sternocleidomastoid. There will be chest in drawing, and there will be a fall in saturation, sir. And he cannot speak a continuous complete sentence.
Correct. And the patient might be leaning forward. He might be fixing his shoulder girdle and scapula to help assist with the breathing, and he will be in a lot of distress. Okay.
Yes, sir.
So if this patient had come with severe stridor, how would you manage him?
If the patient presents to the emergency with severe stridor, I would first try to secure an IV line, give him humidified oxygen, then IV steroids. Then we'll take we'll make him comfortable. Once the stridor settles, we'll have a quick look with the fiber optic laryngoscopy to look for the probable cause of stridor. And if the glottic airway is very much narrow, then he can be taken up for emergency tracheostomy. There we can anesthetize the vocal cords using glottis using topical anesthesia, and if possible,
Okay,
the
so
glottic airways
before we come to that, like all the steps you have suggested are correct. You attach a pulse oximeter, which is a rough indicator of the underlying arterial oxygen pressure, and then you stabilize the patient, secure an IV line, give him intravenous dexamethasone and pantocid, start him on IV fluids, reach the patient, and keep the patient in a semi-reclined position. If you keep him flat, then obviously he will obstruct more. And if the patient is very distressed and he's very agitated, he wants to climb out of the bed, will you sedate him?
No, sir.
Why not?
He'll a mild sedation is okay, sir. Without muscle relaxant, we can sedate him.
So it's better not to give him any sedation at all. His airway is severely compromised. So you reassure the patient. You can give him humidified oxygen.
Okay, sir.
You can give him nebulized adrenaline that will cause a little bit of mucosal constriction. It might improve the airway. And you may even start him on mild sevoflurane before he goes to the operating room. It might help improve the oxygen flow into the airway. And then, like you said, you prepare him for a tracheostomy.
Yes, sir.
If available, is there any other inhalation agent that you can offer the patient to reduce his distress or maybe reduce the labor of breathing? Not often available, but like, yeah, theoretically. Have you heard of Heliox?
Yes, ma'am.
Yeah.
Heliox mixture.
Yeah, I mean, often it is not available in most of the hospitals so easily, but if available, that definitely helps to reduce the, work of respiration and eases out the patient in stridor. Plus, whatever steps that you have mentioned, that is like fiber optic examination. I mean, we at our institute like to do it only in the operative theater setting, not in the outpatient, because in case if you end up inducing some sort of spasm or worsening the stridor, then it becomes difficult to shift the patient, in such a setting. So just always have that in mind, not just for the exam point of view, but your practice.
Okay, ma'am.
Any sort of manipulation done should be done in an operative theater setting.
Okay.
Okay, carry on.
Okay. Ear and nose examination was normal. Contrast CT neck showed tumor involving right vocal cord, including the anterior commissure with extension to supraglottis and subglottis and right piriform fossa, with erosion of thyroid and cricoid cartilage and infiltration of strap muscles. There was no significant lymphadenopathy. RT4N0M0 stage 3. Provisional diagnosis. This is a case of recurrent malignancy of glottis extending to supraglottis and subglottis with right hemilaryngeal fixity with a clinical staging of RT4N0M0 stage 3.
Okay, so what imaging modalities are available for carcinoma larynx, and what are the pros and cons of each modality?
Contrast CT neck, MRI neck, and then we can do a PET scan. Contrast CT neck will show the extent of disease with the neck nodal status, whereas MRI better shows the cartilage erosion like inner cortex of thyroid cartilage which upstages the tumor, and the soft tissue invasion, encasement of carotid like stage 4B and all, it is better appreciated in MRI when compared to CT. PET CT covers the whole body so that we can rule out any secondaries also. Secondaries due to the CA glottis or any other second primary.
So CT scan is the most common investigation done for CL larynx because it is more readily available, it's cheaper, and it's quick. Gives a lot of information, especially inner cartilage erosion, for which CT scan is superior to MRI scan. And then it will give you a reasonable amount of information regarding soft tissue involvement within and outside the larynx. And it's excellent for nodal staging. It's equivalent to MRI for nodal staging. MRI is best for assessing laryngeal cartilage marrow invasion, cricoid marrow invasion, and both will show extralaryngeal soft tissue spread. MRI is probably superior for assessing extralaryngeal soft tissue invasion like thyroid gland invasion, and it's probably better for paraglottic space involvement and the pre-epiglottic fat involvement if you are considering a more conservative treatment option like transoral laser resection. So MRI has its plus and CT has its advantages too.
Okay, sir.
And of course, if you don't do a PET CT scan, then you should assess the chest, which is the most common site for distant metastasis as well as for second primary. And it could take the form of even a simple chest X-ray if the patient is in severe stridor and you need to intervene. But commonly, a contrast-enhanced CT scan of the chest is done.
Okay.
Okay, carry on.
So the investigations and management. Investigations can have contrast CT neck with 1 to 3 mm slices before biopsy, MRI neck, X-ray chest PA view, PET scan for stage 3 and 4 disease, pan endoscopy guided biopsy, routine blood investigations, ECG and echo. In this patient, we took a contrast CT neck and pan endoscopy biopsy was done, which showed moderately differentiated squamous cell carcinoma, and X-ray chest PA view and other blood investigations were done.
So will you do imaging before or after biopsy?
So we'll do the imaging before biopsy.
Why?
If we do a biopsy before imaging, the tissue which we took, the edema and everything will show like the tumor is upstage.
Correct.
So in order to avoid this upstaging of tumor, we'll do the biopsy later on.
Carry on.
As this patient had mild stridor, he was first stabilized, IV line was secured, and IV steroids with humidified O2 was given. Then awake fiber optic intubation was done under topical anesthesia, and airway was secured with endotracheal tube.
So what are the means? Okay, go back to the previous slide. So this patient has come with stridor. He's got a recurrent CL larynx following radiation. And actually the biopsy was done 6 months ago.
Yes, sir.
When the recurrent tumor was small. At that time, patient
Yes, sir.
refused salvage surgery, and therefore he presented in quite a late stage. So we already have the tissue diagnosis with us. But in
Yes, sir.
case this patient presents to you for the first time, having had treatment elsewhere, now he is coming with a recurrent carcinoma larynx. It's a bulky tumor with a fixed cord and compromised airway. Patient is in stridor. How will you proceed?
Sir,
You don't have a tissue. You don't have a tissue diagnosis, and the airway is not secured. So how will you go about it?
so we'll take him to the theater. When he is in severe stridor, as said, IV line, IV steroids, humidified O2, and then we'll do a quick fiber optic laryngeal examination. And if the tumor is completely obstructing the airway, we'll try to do a emergency tracheostomy under sedation, and then we'll secure the airway via tracheostomy, then take a tissue diagnosis by pan-endoscopy guided biopsy, or else we can debulk the tumor and try to intubate.
Okay, so what you said the first time is probably the safe. The first option is probably the safest. You will do an awake tracheostomy under local anesthesia. Secure the airway first. So first secure the airway to save the patient's life. And then once the tracheostomy is done, you can give a general anesthetic through the tracheostomy, and then you can do a thorough pan endoscopy to assess the extent of the lesion. And then you can take a biopsy. And if the biopsy confirms squamous cell carcinoma, you can take up the patient electively for salvage surgery at a later date. So this is probably the safest option available.
Yes, sir.
There is another option where you're reasonably sure this is recurrent tumor and the patient has airway obstruction. There is a theoretical risk that if you do a tracheostomy and do a salvage procedure later, the tracheostomy site can be seeded by tumor. So if you want to avoid it, and if the patient is in a mental state where he can understand the counseling you do for a total laryngectomy, you can do a tracheostomy, take a biopsy for a frozen section, and then proceed with definitive salvage surgery straight away. So that is the less common option that's available. And the debulking the tumor with laser, it's fine in theory, but it's not always practical, and it's quite dangerous in a situation like this. So perhaps for completing the answer to an exam, it can be said, but it's not the advisable option.
Okay, sir.
Dr. Neha, you want to?
No, I just wanted the same point that I was about to touch, that the debulking is rarely done, and that too maybe in just primary settings where the CO2 lasers are available, but it's never advisable in a recurrent tumor setting. It's safest to just do a tracheostomy and then do a pan endoscopy.
Okay.
We have some questions coming up on the chat box. We'll answer them later after the presentation. Okay, carry on.
The patient was taken up for pan endoscopy, followed by total laryngectomy with partial pharyngectomy and right hemithyroidectomy. Right selective neck dissection with central compartment neck dissection was done with reconstruction using pectoralis major myocutaneous flap.
Okay, so just going back to the question of tracheostomy, there are two sayings regarding when to decide to do a tracheostomy. First is, if you think of doing a tracheostomy, do it, because even though there are drawbacks to tracheostomy, more often you are proven right by doing a tracheostomy. So if you think of doing a tracheostomy, do it right away. That's first. Second is, don't let the sun set on a patient with stridor. That is the other saying. So you have to secure the airway immediately during the daytime when all the staff are available and if you have all the other expertise available. I don't mean to say if the patient comes in the middle of the night, you need to wait for the next sunset to happen before you do the tracheostomy. Right? You know what I mean. So you need to do the tracheostomy as quickly as possible. So that's the second thing.
Okay.
Okay, so this patient had a salvage laryngectomy, and what's the purpose of using a flap in this patient?
Sir, instead of primary closure, we have reconstructed the pharynx with pectoralis major myocutaneous flap that helps in better healing. Especially in this patient, he's a post radiotherapy candidate, so he'll have the neck tissues and the vessel. Better to go for a vascular flap than primary closure.
Okay, your audio is not clear, Sneha.
Hello, sir.
Yeah, now it's clear.
Okay, sir. Since he's a post radiotherapy patient, he has neck tissues, and the vasculature of the neck will be poor. So instead of primary closure, it is better in this patient to go for a pectoralis major myocutaneous flap, which helps in better healing and avoidance of pharyngocutaneous fistula.
Okay. So what are the other flaps? What are the other options you have apart from a pectoralis major flap?
So we can reconstruct using free flap like radial forearm free flap or fibular free flap, or else we can go for a primary T-shaped closure when we have adequate pharyngeal mucosa.
So we don't need a bony free flap like a fibula. We need the, like you said, a radial forearm flap would be the free flap of choice in this situation.
Okay.
And like you said, you could do a primary closure, but probably for better wound healing, it's better to utilize a flap with the skin paddle of the flap either being incorporated as part of the pharyngeal mucosa, or you can just lay a muscle flap on top of a primary closure. I usually prefer to incorporate the skin paddle to form a neopharyngeal lining so that the chances of stricture later on are much less.
Dr. Sneha, instead of the fibular flap that you mentioned, ALT is a still better option. I mean, the radial free forearm is the best, and the ALT is the next. However, it's more bulky, so we tend to avoid using that. I mean, people have used gastromental flaps also, but I think PFMC is mostly preferred in most of the institutions because it's a very, very, well vascularized and very hardy flap, so it doesn't go necrosis that easily.
Okay, ma'am.
And can you tell me, like, what is the minimum length of the remnant mucosa that you can use for primary closure?
6 centimeter, ma'am.
Is there any differentiation between relaxed and stretched mucosa, or is it like always 6 centimeters?
It is like 6 centimeter unstretched pharyngeal mucosa should be available to close it as a primary closure.
Okay, good. Carry on.
So this is the post-operative image and barium swallow of the patient, which was done 2 months after surgery. So here the barium swallow shows no leak. Here the stoma is completely healed.
Okay, so how do you rehabilitate the voice of this patient?
Sir, Like we can esophageal speech is one option, or electrolarynx, or we can during the surgery we can we can use tracheoesophageal puncture for voice rehabilitation at the time of surgery, or else as a second step surgery.
Okay. So as you can see, this patient didn't have a primary tracheoesophageal puncture done,
Yes,
and
sir.
we opted for electrolarynx as the initial voice rehabilitation because of the history of previous radiation and possibility of poor tissue healing.
Yes, sir.
Okay, carry on.
So as mentioned, there is no filling defect or no leak in the barium swallow. So the post-op pathology report came as moderately differentiated squamous cell carcinoma of stage RPT4A N0M0, stage 4A.
Can you comment on the margins?
Yes, sir. So the anterior margin was 0.5 centimeter away. The right lateral soft tissue margin was 0.2 centimeter. The right posterolateral soft tissue margin was 0.1 centimeter away. Right piriform fossa mucosal margin 0.2 centimeter away. And the tracheal margin 2.8 centimeter away. All the margins were negative, free of tumor.
So the margins are clear. Are they adequate?
Adequate, sir.
Or what is an adequate margin
Uh,
in millimeters? How many millimeters do you expect the
5,
margin to
5
be?
mm.
So here the closest margin is only 1 millimeter
Yes, sir.
along the right posterolateral soft tissue margin. So technically it's a clear but close margin.
Okay, sir.
This was a bit of a surprise. It was a completely endolaryngeal tumor, and the piriform sinus mucosa was a good cuff of normal-looking mucosa around. What appeared intraoperatively as adequate was removed, but you still end up with a close margin pathologically. So, what is the reason, do you think?
Probably the post-op radiotherapy caused fibrosis of the tissues.
So, how much margin do you normally aim for grossly during resection? Not only for laryngeal cancer, but any other head and neck site. What is the gross margin that you aim for during surgery?
Gross margin is 1 centimeter, sir.
Okay. And then pathological
Pathological is 5
margin.
millimeter. Histopathological is
So,
5 mm.
so there are two shrinkages that happen that you need to account for.
Okay,
So
sir.
when you resect the specimen, the moment you take the specimen out, the tissues, they lose their stretched in situ status and they shrink by a few millimeters. And then when you keep the specimen in formalin and when you fix it, it shrinks by a further few millimeters. So in order to achieve a 5 millimeter pathologic margin, you need to take 10 millimeters intraoperatively. So that is the aim. It may not be technically possible in all circumstances, but this is a margin that you aim for. Now, in this case, it is a close margin. Probably the piriform sinus mucosa shrinkage is a factor, but still we need to keep a very close eye on this patient for future recurrence in view of the close margin.
Okay, sir.
If it happens, then maybe he may not be suitable for any curative treatment, but hopefully he will do well, at least for the time being. So we'll take some questions from participants. A lot of people have complained there's no audio. Okay, hope everything got sorted out during the course of the presentation. So the question is, what mixture of oxygen with another drug was said? Dr. Neha, you're still around?
Yeah. So helium and oxygen, heliox is a mixture, and it basically reduces the viscosity of the breathable air, and it therefore reduces the the friction between the tissues and reduces the labor of breathing. So it kind of eases out the patient a bit.
So there's a question as to how to differentiate between vocal cord paresis and fixity. Sneha, can you elaborate?
So vocal cord?
How do you differentiate between vocal cord paresis and vocal cord fixity? How do you differentiate between the two?
In vocal cord paresis, there will be at least flickering of vocal cords, whereas in fixity, there will be complete absence of movement. In paresis, the cricoarytenoid joint will be mobile, whereas in or else we can see movements with the arytenoids. Here we'll see the fixation with the cricoarytenoid joint. There will be shortening of vocal cords in vocal cord fixity, whereas in paresis it appears to be lengthened.
Okay, I think the key point you made is you need to check for cricoarytenoid mobility. You can only do it under general anesthetic. So if there is fixity of the vocal cord due to cricoarytenoid fixation, you won't be able to move it. But fixity can also be due to tumor infiltration, deeply invasive tumor in the paraglottic space that can also cause fixity. And like you said, a paresis is a partial weakness. You'll have at least a slight movement of the vocal cord. So I think it's a good time to talk about stroboscopy. So what do you know about stroboscopy and how does it help us differentiate various movement disorders and pathology?
So it's a form of flexible or rigid endoscopy which uses flashes of light to record, which takes series of images of vocal cord and they are projected in sequence so that it appears as a sequential motion. So where we can address the glottic closure or any mucosal disorders like vocal cord polyp, nodule, or tuberculosis can be addressed. So it works on the principle of Talbolt's law.
And what is the mucosal wave in stroboscopy?
With the vibrations of the vocal cords, accordingly the flashes of light will be thrown. The vibrations are assessed with the microphone and accordingly the flashes of light will be synchronized to assess the mucosal vibration.
You look for areas of disruption in the wave, which means there is pathology in that area. Right? So there's a question regarding patients with stridor. Can we use IV atropine along with humidified oxygen and IV steroids and adrenaline nebulization before shifting to OT? Will it act as a pre-medication and decrease the secretion? I personally don't use atropine because it does give a mild sedation and I haven't tried it. I'll have to ask the anesthetist whether it's helpful. Dr. Neha, any comment?
We haven't had that experience with atropine, and we rather just simply go for a steroid and adrenaline inhalation and ship it. No, I'll talk to my anesthetist about it.
Yeah. So another question, what is the ECOG score for this patient? basically, question is asked about the performance status of the patient. We didn't do a formal ECOG score for this patient. The other scale is obviously the Charlson Comorbidity Index, which predicts how long the patient will live, expected life expectancy, and depending on that, you can tailor the treatment. We didn't do a formal ECOG score, but we do get a formal cardiac assessment. If necessary, we get a pulmonology assessment. And then we just ask generic questions like whether the patient can climb stairs, he can do his normal day-to-day work, if he can walk without much breathlessness. But obviously this patient is in stridor and he had no other major comorbidity. So we didn't formally assess for his ECOG status. Another question is, how do you manage and treat different stages of laryngeal tumor? Sneha? So T1, T2, T3, and T4.
T1 and T2, which are grouped as early laryngeal carcinoma, they can be taken up like first choice can be radiotherapy or transoral laser microsurgery. In case of T2 and then the second option will be open partial laryngectomy. And in case of T3 and T4, which are grouped as advanced laryngeal cancers, the T3 will have first choice as chemoradiotherapy and second choice as total laryngectomy. T4 will have the first choice as total laryngectomy and the second will be chemoradiotherapy.
I think that broadly covers the treatment strategy. What are the pros and cons of transoral laser resection versus radiation for early stage glottic carcinoma?
In case of early stage glottic carcinoma, radiotherapy is preferred in case of large tumors. When the lesion is quite small and it occupies mid-cord, it can be easily approachable with transoral laser microsurgery. And patients who have like restricted mouth opening, trismus, prominent teeth, who cannot be positioned for direct laryngoscopic, transoral laser microsurgery, they can be taken up for given the option as radiotherapy. Patients who have cervical spondylosis and the patients who are dependent on their voice as profession like singers, teachers, they can prefer radiotherapy because it doesn't have any structural damage to the vocal cords compared to transoral laser microsurgery. And when the tumor extends to the anterior commissure, it's difficult to expose using transoral approach. Rather than they can go for radiotherapy.
Good. So on top of all the points you have said, a patient who cannot come for regular follow-up, he is better suited for radiation.
Right.
Because transoral laser resection, you get only very, very narrow margins, like sometimes even 0.5 to 1 millimeter is the best you can get with transoral laser. And therefore, these patients need very close follow-up. So a patient who is from a remote place is better suited for radiation. All the studies that compare transoral laser versus radiation include patients who undergo repeat surgery in the transoral laser arm. So the evidence kind of overestimates the effectiveness of transoral laser in this way. So it is kind of biased, and that's one of the drawbacks. But the advantage of laser is you can repeat it as many times as you want, provided the patient is willing to bear the cost and the multiple general anesthetic. What is the position you put the patient in for direct laryngoscopy?
Sir, boy's position with flexion of neck and extension of atlanto-occipital joint by placing a shoulder
And how do
roll
you achieve?
underneath the shoulders.
You'll keep a shoulder roll. So the position for a direct laryngoscopy is basically you bring the everything in one line for the rigid laryngoscope to go from the level of the teeth till the level of the supraglottis. So it should be one rigid straight line so that you can pass the scope without using the upper teeth as a fulcrum to rest the scope. So that's how you avoid damage to the teeth. And in order to achieve that, you should lie the patient on the table without a shoulder roll or a head ring, and it will put him in a position where the lower cervical vertebrae are in flexion and the atlanto-occipital joint is an extension. So in this position, you can slide the laryngoscope through the oral cavity and you can follow the endotracheal tube if the patient is already intubated. And using the blade of the laryngoscope, you lift the epiglottis anteriorly without exerting any pressure on the upper teeth, and you can have a look of the larynx. What options do you have if the access is limited during a direct laryngoscope?
We can give cricoid pressure so that we can visualize the larynx better.
Okay.
We can use an anterior commissure scope so that we can have a better vision.
Okay.
Or else we can push the tongue to one side and slide through. In case of broad tongue, we can.
Okay, so these are all good points. And of course, this is the advantage of giving a general anesthetic. If you give a general anesthetic, rather keep the patient sedated and try to do it, you won't get adequate relaxation. So if you give a general anesthetic, you can completely paralyze the patient, and that will give you a lot of room to, it'll relax all the pharyngeal muscles, and you'll have more space to negotiate the laryngoscope. And then you have a lot of other types of scopes as well, like the VIDA scope, the FK retractors, and they all give you more adjustment and exposure to get into, especially the anterior commissure area, which is the most difficult to access.
Yes, sir.
What precautions do you take during transoral laser surgery?
Sir, like we should take the precautions while using a laser, like the operating person as well as the assistants and the staff nurse should wear laser protective goggles, and the endotracheal tube cuff can be inflated with saline, where in that place we can use a double lumen tube, and we can protect the airway with saline soaked gauze piece around the endotracheal tube in order to prevent thermal damage. Then we can limit the usage of inhalational anesthetic agent and oxygen, and we should be aware that no other inflammable gases are in the operating room.
Dr. Sneha,
Good, that pretty much, yeah.
Dr. Sneha, do you know the most safe and most commonly used carbon dioxide laser settings?
Yes, ma'am.
Are you aware of the settings of the laser machine? I mean, which is most oftenly used by the operating surgeons and considered safe?
Like it's 5 watts to 7 watts with 0.5 mm of the dot, and the
usually in pulse mode.
pulse mode.
So it can be either regular pulse or super pulse. So you're correct. Usually 5 to 10 watt pulse strength is the one which is commonly used and it's considered safe.
Okay.
So how do you handle airway fire during laser surgery?
Will immediately uh, cut off the
Stop using
laser,
the laser.
stop using the laser, then will immediately inform the anesthetist like there is an airway emergency, and will take out the endotracheal tube and put the patient on mask ventilation, cut off the inhalational agent and O2. We can pour cold saline into the airway and then re-inspect. Once the situation is stabilized, we can re-inspect the airway to look for the thermal damage.
Okay, everything you've said so far makes sense, but why do you want to extubate the patient? What's the purpose?
Sir,
So you would like to keep the airway secured. There's no rush to extubate the patient. Like you said, stop the oxygen, flood the field with saline. So that's why you have the endotracheal tube cuff inflated. And then once the patient is a little bit more stable and you've gathered yourself, once the fire is out, then you can reassess the situation and then decide whether to keep going ahead with the surgery or abandon, stop right there. And then once the patient is safe, extubate the patient. So that's the way to go about it.
okay, sir.
It's very rare that a fire causes a severe degree of injury. It's usually you can pick it up early and stop it. And provided all these precautions are followed, it can be dealt with without much of morbidity to the patient.
Okay, sir.
So there's a question regarding steps of a laryngectomy. So can you elaborate in just
Yes,
the common steps of a laryngectomy?
sure. We'll use a Gluck Sorensen apron incision or transverse skin crease incision, and then subplatysmal flap elevation. Then we'll separate the strap muscles from the sternal attachment. Then we'll delineate the hyoid bone and separate the attachments of muscles from the inferior part of the hyoid. We'll identify the superior thyroid pedicle, then ligate it, preserve the parathyroid. We'll do a whichever side is affected, we'll do hemithyroidectomy on that side. And after delineating the hyoid, we'll enter the pharynx so that we'll see the epiglottis there, clamp it, and then lower down we'll do a tracheostomy with a new, if it is a patient without previous tracheostomy, we'll do a tracheostomy lower down and then create a skin stoma, suture the tracheostoma to the skin side. Then we'll resect the entire larynx with the partial pharyngectomy. Then we can
Okay, good. Yeah, that's good. So my comment is it's preferable not to do a U-shaped Gluck Sorensen incision, which will incorporate the stoma in the incision. That's got a higher risk of fistula formation. It's preferable to use a horizontal, slightly higher neck skin crease incision and leave at least 2 to 3 centimeters gap between this incision and a separate stoma. There's an excellent question whether there's any role for post-op radiation in this patient because of the closed margins. It's probably not of much use because it's been only less than 2 years since he had radiation. Another dose of radiation within such a short time will not be effective, and it's very toxic also. Dr. Neha, any closing comments? I think it's almost time.
I had a few questions. I just wanted to ask, Dr. Sneha, do you know of any things that you can do, any steps that you can do intraoperatively to reduce stromal recurrence?
will freshen. If the patient had a previous tracheostomy, will freshen the skin margin
Hmm.
and create a new tracheostoma, resect the previous one,
Okay.
so that we can avoid stomal recurrence.
And then one more important step. Make sure you do a meticulous level 6 dissection, because that is where most of the times the metastasis and the lymph nodes are there, and that is the one that causes the stomal recurrence.
Yes.
So good level 6 dissection. That's good. Thank you.
Thank you. One last question. It's a good question. It is why do a selective neck dissection? Because the preoperative imaging didn't show any enlarged neck nodes. That's an absolutely valid question, because in the end, we did find there was no occult nodal metastasis on pathology. It prolonged surgery, and it's probably causes more higher risk of post-op hypocalcemia, chyle leak, and all that. It's an excellent question. The risk of occult nodal metastasis in a salvage setting is approximately 10 to 15%. This is the patient's last chance. So we didn't do a bilateral selective neck, it was unilateral. And on balance, we thought the morbidity of additional surgery is less than the possible benefit he might derive if he had occult nodal metastasis. So thanks everyone for your participation. It's been a pleasure, and thanks Dr. Neha and Sneha for an excellent presentation, and hope we'll catch up sometime soon.
Thank you, sir. Thank you, ma'am.
Thank you. Bye.
So thank you very much, trainees and faculty members, for joining this session.